I loved taking care of women through kind of all walks of life, you know, adolescence through our late 60s, 70s, 80s. I love delivering babies, so it was just a natural choice for me to choose OBGYN when I was in training, and I'm thrilled that I have.
All right. Well, next, Dr. Siewert, tell a little bit about your background and what brought you to South Dakota.
I was born and raised in Yankton, South Dakota.
Excellent.
So I came back home after training. I've always wanted to be a physician, and in medical school I had experience with labor and delivery and just fell in love. And then also just loved being able to take care of a woman throughout the stages of her life, including perimenopause and menopause, which is now my new current passion in my practice. So as I started getting older, my patients started getting older, and that's when I really started getting interested in the care and the specific needs of these patients. So that's why I'm here tonight.
Excellent. Dr. Wood, too.
Yes.
We've got extra guests. This is great.
Thank you for having me. So I grew up
Yes.
on the East Coast and did my urology training on the West Coast because I was sick of the cold weather. Joke was on me. The love of my life was from South Dakota, so here I am. And I did some specialty training in female pelvic medicine, reconstructive surgery at UCLA, and have been taking care of women ever since I moved to South Dakota 8 years ago, and only recently became interested in the menopause space, as I think, you know, the more and more we're learning and a huge need for that care. And so I've done some continuing education, and so I appreciate you guys letting me be a part of the conversation tonight.
Yes, I'm glad I kind of took this show on just because I'm a woman of a certain age, so this was very near and dear to my
As
heart.
we all are.
Yes.
All right. Well, before we get into our discussion, I just want to pause and express my gratitude to all our viewers. As an independent 501c3, each dollar you contribute goes a long way in helping us create meaningful content that guides individuals in making informed health decisions. Thank you for contributing to Prairie Doc. Now, let's turn our focus to you, our audience. We invite you to submit your questions for tonight's conversation on perimenopause and menopause. There are 3 ways to reach us. Call us at 1-888-376-6225. Send an email to ask@prairiedoc.org, or engage with us on our Prairie Doc Facebook page. We will do our best to address as many of your questions as time allows. If we can't get to yours, we sincerely apologize. All your questions are anonymous and no information will be saved. However, if you would like to leave your name, email, or phone number, you'll be entered into a drawing for our Prairie Doc publication, Perspectives from the Prairie. But it is not a requirement to submit a question. We'll announce the winner at the end of the program. Well, lots of questions already that have come in before the show even started. So I know this is a topic near and dear to half the population that most women will experience. So we'll get started here because I know more will come in as the show progresses. So our first question is, patient is almost 64 years old, went through menopause when she was around 50 to 51, never had any of the symptoms you hear about, no sweats, weight gain, depression, etc. States that they've always eaten healthy and exercised, have taken calcium supplements since they were 20. They want to know what to do for intercourse. They say they still can get lubricated on their own, but it takes a lot more effort. They've tried some things, but they always seem to burn or are irritating. What can they do to help with that? Because that's still a very big part of someone's life.
Absolutely, yeah. We want our patients to have healthy, active sex lives if that's what they desire, especially into menopause, 50s, 60s, 70s, whatever it might be. And the vaginal mucosa is very estrogen sensitive, and so when you go through menopause and your estrogen levels drop off, that tissue is particularly affected, just like every system throughout our body, but the vagina in particular is very affected by this. And so I would recommend vaginal estrogen therapy for this patient in particular. She certainly is a candidate. It sounds like there really are very, very few contraindications to using vaginal estrogen therapy for dryness, painful intercourse, frequent UTIs. The list goes on and on, so I'd start there.
All right.
Also, using a vaginal moisturizer is really, really important. One of my favorites, at least from what my patients tell me, is coconut oil. Using that every night also is an excellent lubricant as well. So it has dual benefits. But that is really important. And sometimes pelvic floor physical therapy can be really, really helpful if there's pain associated with intercourse that isn't remedied by the vaginal estrogen.
Okay. So a couple of options out there.
Yes.
Wonderful. Well, next question is, a viewer says that they are almost 50, started hormone replacement therapy 7 months ago, and it's helped with most of the worst symptoms. Recently, the past 3 months, in the 7 to 10 days leading up to their period, a lot of the symptoms start coming back. They talk to their OB/GYN and asking about increasing the dose of the hormone replacement therapy, and she mentioned that the symptoms were probably just cyclic. Would an increased dose help when those symptoms come back the week prior to the person's period? She's on 0.25 milligrams estradiol patch once a week. So,
I think that, certainly her symptoms are cyclical because it sounds like she's perimenopausal, so still going through the different stages of increase and decrease in hormones. I think potentially trying to increase her dose would possibly help. Also, sometimes using just what we term oral contraceptive pill can help decrease those cyclic fluctuations that occur throughout her cycle. But if she's doing well on her current patch, it's possible that an increased dose could help, or the addition of a higher dose of progesterone around that same time may help supplement those hormonal fluctuations that are contributing to her symptoms.
all right, great. Well, hormone replacement therapy is a treatment used to supplement hormones the body no longer produces in sufficient amounts. It is commonly prescribed to alleviate menopause symptoms such as hot flashes, night sweats, and mood swings by replenishing levels of estrogen and progesterone. Dr. Annette Siewert, Avera OB/GYN and certified menopause practitioner with the Menopause Society, shares more on the history and current recommendations of hormone replacement therapy.
Pelvic floor PT is just applying what we use in regular physical therapy to the pelvic floor. So for someone who has a dysfunction in their life, such as bladder leaking, bowel dysfunction like constipation or leaking, or pain with intercourse, as well as people who are both pregnant or postpartum.
Initially, synthetic estrogen was made in the 1930s and 1940s, so a long time ago, and they actually used the urine from pregnant horses, and so it's called conjugated equine estrogen, and so that was the first estrogen ever developed. And they discovered that it could be helpful in women who are experiencing the vasomotor symptoms that we have in menopause, like hot flashes and night sweats.
After a few decades of use, the promotion of estrogen for women's overall well-being was popularized in the 1960s.
The trial was a randomized control trial, which is like the gold standard of research trials in medicine. And the arms included estrogen and progesterone therapy for women who have uteruses, because if you have a uterus, you have to take progesterone with your estrogen. They also had an estrogen-only arm as well as placebo arms for each of those groups. Within that study, I'm not quite sure the exact timeline, but only a few years, they noted that there was a slight increased risk of breast cancer in the estrogen and progesterone arm compared to the placebo. They continued the estrogen-only arm for a few more years after that, but because of this slight increased risk of breast cancer, they stopped the study because that's all studies have a safety stop.
Dr. Siewert says the study itself obtained important results, but the way the information was relayed to the general public caused more harm than good.
How it was relayed to the public was through a Today Show press release that was done in July of 2002, and most of us who are in this field remember when this occurred because it was a big deal, probably one of the biggest things that's happened in OB/GYN in our history. But because of this slight increased risk of breast cancer, they did this press release, and then everybody got scared about breast cancer and stopped their hormones at that time.
She adds, since then, the study has been discredited.
So there's been a lot of studies sort of debunking that overall sentiment that hormone therapy causes breast cancer. But really there's been a re-looking at that data to say that actually this risk was very slight. It barely met clinical significance. So for example, in the estrogen and progesterone arm, which is where the increased risk of breast cancer showed, that risk, when you relate it to so the general public can understand it, is only about 1 person out of every 1,000 per year.
Well, I did my training right when that Women's Health Initiative study came out, and it was drilled into me, do not put women on hormone therapy, get them off of it if they're on it, this is terrible, you know, you're putting them at so much risk. And as we found in medicine, things change. We find out new information, studies are revised, and we treat things differently when we get more information. So I know definitely want to talk about that risk of breast cancer, which is what everyone had on their mind with that initial study when it came out. Do you want to talk a little bit more about that?
Nothing more than to discuss this. So if you learn nothing else this evening, please know that estrogen does not cause breast cancer, okay? Just like a fire needs oxygen to spread, we don't avoid oxygen for fear of being on fire, because oxygen does not cause fires. So estrogen may be a target of some breast cancers, and we can target that therapy, but that doesn't mean it's the cause, okay? So as Annie very well discussed, the WHI, that slight increased risk in breast cancer was in only the estrogen and progestin arm, and those were both synthetic medications we don't use today. It was not statistically significant, meaning in scientific terms, it basically wasn't, it's not real, right? So we now know that the women in the placebo arm who were getting no active medication were actually had a higher use of hormones previously, which falsely lowered their risk. So even if you wanted to vilify anything, okay, we could say maybe it was the synthetic progestin, but we now know that even that was not an issue. And the real kicker for me is that women in the estrogen alone group had a decreased risk of breast cancer. Let me say that again. Women who just use estrogen because they did not have a uterus and therefore did not need to use progesterone had a lower risk of breast cancer. So there is no family history that would preclude you from using hormones. And if you're concerned about breast cancer, great. I would encourage you to talk to your doctor about estrogen, which may be protective. Furthermore, women who use hormones tend to do better and have a better prognosis and lower mortality, lower death from breast cancer. And just to hammer this point home, breast cancer, while it does kill, it does kill women, right? But 90% of breast cancers are curable, if not more. The #1 cause of death in women is heart disease. It kills almost 7 times as many women as breast cancer. And if you use estrogen, it will decrease your risk of heart disease by 50%.
Wow, that's amazing.
Yeah. And so, yeah, anyway.
Yeah.
We're all very passionate about this topic, especially.
That's good. That's why you're here. So how long can a woman take estrogen? The viewer says they're in their late 60s. Do they have to stop? Because sometimes it was that 10 years was kind of the recommendation that I've heard thrown around. But
yeah, so when we were in training, we all were taught lowest dose possible for the shortest amount of time needed for symptom control. That whole verbiage has kind of gone out the window, which I think is wonderful. I always go back to one of my favorite menopause experts. Her name is Lauren Stryker. She's from Chicago. She's a brilliant lady. She was in charge of putting together an expert panel for the Menopause Society, or at that time NAMS, I think, meeting. And she was supposed to find people who would say, this is when you should stop your hormones. And she couldn't find a single person in the entire country who would say, this is the year that you should stop, or this is how long you should be on it. So I think we're all pretty comfortable with people continuing hormones for a long time, as long as their risk factors hasn't changed.
Yeah, I think you really have to lay the groundwork with your patient to say, we're going to start this, we're going to revisit this annually, we're going to reassess, changes to your medical history, risk factors, things of that nature. But there's not like a line in the sand anymore where you say you turn this age or you've been on this many years that you have to stop. It's an ongoing discussion with your patient.
And what other medication do we arbitrarily stop after 10 years? I mean, we don't prescribe cholesterol medication or high blood pressure medication and say, well, we're going to treat you, but only for the next decade, and then good luck. That's just not, that doesn't make a lot of sense.
Yes. All right. Well, there's another viewer interested to learning more about supplement use during perimenopause. So there's lots of things. My Facebook feed is constantly filled with supplements that I'm trying to be sold. some that I can't even pronounce. The B vitamins, Vitex, Inistol, Ashwagandha, you guys say that. Yes. So what are your thoughts on those? Are they helpful?
Yeah, I don't think we have any data to say like take this, this, and this as being treatment or symptom relief options for patients in menopause. I think that's really patient specific. I certainly recommend, you know, good multivitamin, calcium, vitamin D for women of all ages. Getting into the nitty gritty of a lot of those specifics, I think probably are a little bit more of a marketing scheme against patients than anything else.
Yeah, there's definitely buyer beware, especially on social media. I think there's a little bit of data regarding ashwagandha and kind of in like for shift workers, like as far as like similar to melatonin, where you can get a decrease or like help it to fall asleep. But otherwise, there's not a lot of data on that one. Creatine has some pretty interesting stuff coming out recently that it could be helpful for muscle building, energy, brain, mood. So I think that one's pretty popular and has some evidence behind it. Magnesium for all things.
Everyone can use more fiber.
Yeah.
But if you're using supplements to manage, if you can buy it on Amazon, it will probably not manage your menopausal symptoms as a general rule.
All right. Well, a viewer says, what's the best remedy for hot flashes? They're hot all the time. Are there medications they can take that will help?
Estrogen.
Okay.
Estrogen is the most effective medication that we have for treatment of hot flashes. So that's kind of the gold standard of treatment, but there's other options as well. There's SSRIs, like antidepressant medications that can be helpful. Oxybutynin is a medication that we give for stress or kind of urge incontinence. Thank you, urologist. And that actually has some good data behind it, but also there can be some pretty significant side effects with that one.
All right. Another viewer says, they are in perimenopause. Not even one glass of wine at night makes me feel horrible in the morning. Does this stop when I enter menopause?
I hope so.
We get the exact same feeling, so we can relate.
Try drinking earlier, add water.
Yeah.
So, all right, another patient says, my ears have been itching since entering perimenopause. Is this a symptom because it comes and goes with my cycle?
It absolutely is a symptom. It's one of those obscure ones. There's a handful of them, but it absolutely is one that's been identified as a symptom of perimenopause.
What are some of the other odd ones that you think of?
Yeah, I mean, I think most people just think hot flashes, night sweats, and irritability, waking, but joint pain can be a significant symptom of perimenopause and menopause. There's something specific to like the orthopedic community called frozen shoulder that a lot of women will experience, but a lot of like chronic neck pain, low back pain is a very common symptom. Heart palpitations,
Very common. Ringing in the ears.
Vertigo.
Okay. Yes, there was a viewer that was asking about shoulder pain with perimenopause. What can be done for it?
Estrogen replacement, yeah.
I'm noticing a trend.
Yes.
All right. So another viewer says they developed hypertension during menopause and into menopause. Is there a link between menopause and high blood pressure?
I think like the cardiovascular system in general goes through so many changes as we age, so we tend to see, you know, hypertension become more apparent in aging adults. We inherit other risks at that point too. Our risk of diabetes goes up. We see more rates of obesity, so it's probably like a multifactorial, you know, age-related phenomenon more than it is specific to menopause and perimenopause.
Okay. There's another viewer, 49 years old, finally started Cariva Volena a couple of years ago after a lifetime of very heavy, painful periods. My periods and symptoms have been pretty much stopped, though I do notice a few perimenopause symptoms, but nothing severe. Is there a way I can know when to stop taking birth control? Or could there be harmful effects of taking it longer than needed? I got this question a lot in primary care. When do you know when to stop?
We don't, so we were all discussing this before the show, and I think most of us would stop it for certainly at the natural age of menopause, which is 50 or 51. Up until then, you don't have to stop it. If it's helping you, then you could just continue it. But of course, you won't necessarily know when you actually go through menopause until you stop it. But also we don't really care. I mean, we do, but we don't need to have that information to treat you with, hormones. So you could transition from the pill, oral contraceptive pill, right to hormone replacement therapy if you need to.
Excellent. Another viewer hitting the other end of the spectrum is 91 years old and has been struggling with urine leakage since menopause. Is there anything she can do to alleviate this, or will she live with this for the rest of her life?
Absolutely not. She does not have to live with that. So we've talked about this before on episodes, but it depends on the type of incontinence, whether it's with activity or with urgency. First thing I say, you don't need to drink water unless you're thirsty. Try to pee on a schedule, minimize caffeine. If none of those things are working, there are medications. If it's leakage with activity, there are procedures, and these things can be done in the office. So I treat tons of women in their 90s for urinary incontinence, and there is no reason to suffer. Another thing that also helps, vaginal estrogen, fantastic at all ages. It is acceptable for almost every patient, even those with a history of breast cancer, regardless of what your oncologist says. That's a shared decision-making opportunity for you and your physician. So vaginal estrogen can also help support those urethral tissues and improve urinary incontinence as well. So I use it a lot for my overactive bladder patients regularly.
Excellent. Another viewer says, my doctor only recommends birth control for my perimenopause symptoms. Does it help, or would hormone replacement therapy be better? What's the difference between the two? It means both estrogen, progesterone. Can you explain the difference between hormone replacement therapy and birth control?
Typically, doses of oral contraceptive pills are higher hormone replacement than you would get in like a transdermal estradiol patch and a micronized progesterone pill. So I think it really depends on what your symptoms are. Some patients do much better on a combined oral contraceptive pill to manage their hormones. It's not a one-size-fits-all, so I really think it depends on how your patient presents to determine which. If there's no contraindication to them using a combined oral contraceptive pill, it's a nice option for women who are perimenopausal, so very reasonable.
Especially those perimenopausal women who are experiencing irregular bleeding, it can be really helpful because it's really good cycle control. Or if their symptoms are really cyclic in nature, because it causes ovarian suppression, whereas like hormone therapy, estradiol, will just kind of put a Band-Aid per se, whereas the birth control pill will suppress the ovaries from doing their chaotic things that they're trying to do during perimenopause.
Okay. So it's not stronger. The hormone replacement therapy isn't stronger.
Oh no, it's way weaker.
Less.
It's less.
One of the downsides, though, that I see, especially in urology, of oral contraceptive pills are because they turn the ovaries off, and then you're replacing the estrogen and the progesterone with the contraceptives. Your ovaries no longer make testosterone either. And so I see a lot of symptomatic women who their bodies are acting like they're going through perimenopause in their vagina, or in terms of libido and energy and things like that, where testosterone is also made by the ovaries. And so that's one downside of possibly considering, okay, well, maybe if you're having heavy periods, place an IUD that secretes progesterone and then add in that transdermal patch so that your other hormones aren't affected.
Yeah, that's a great point.
All right. Well, I'm seeing a couple of different doctors here where this one viewer says, my current OB does not recommend hormone replacement therapy at all. Should I talk to another doctor about my perimenopausal symptoms? I'm having hot flashes and anxiety every month around my period.
I think unless your current doctor can give you a reason you should not be considering hormone replacement therapy, like an absolute contraindication, of which there are very, very few, active liver disease, estrogen receptor positive breast cancer, unexplained vaginal bleeding, history of blood clots, DVTs or PEs. If you don't meet criteria for an absolute contraindication and you're still hearing no or getting pushback from your provider, I would say you're not really being heard, and it's absolutely in your best interest to find someone who will listen to you.
Because changing the way you practice for 20 years is a hard thing for a lot of doctors.
And it is a lot of just miseducation and fear, which was instilled in all of us through the Women's Health Initiative. And I think just it behooves a provider to educate themselves. And if you don't feel comfortable, that's okay. There are plenty of us, in the area who are willing to lead the charge on this and do what's best for women. And so certainly advocate for yourself and find someone who's willing to address it.
I think it's also really important to know that when there's been so much of this, well, is it really that bad? I mean, are your symptoms really that bad? Well, it's not just night sweats and irritability. Women who have vasomotor symptoms like hot flashes and night sweats are more likely to have cardiovascular disease. And we know that estrogen is protective against cardiovascular disease. And so, in medicine, no one's doctor is trying to hurt them. Everyone's physician thinks they're doing the best, but we know better now and we have to do better. And just because you don't know how to prescribe hormones or you don't know the benefits all on your own, it doesn't mean that it's not the best thing. And there is harm in not offering that to people. What is the risk and what is the harm in not providing that? Just because I don't know how to use a seatbelt doesn't mean that not wearing seatbelts is the right thing. It is not the safe thing. I need to learn to put my seatbelt on so that I can do better.
So, viewer asked, why do I need progesterone and the estrogen patch at the same time?
So, if you take estrogen in any form, you should have something to protect the uterus against the estrogen effects, because estrogen causes proliferation of the endometrial tissue or to the uterine lining, because that's what it's supposed to do. And if you don't have the counterbalance of progesterone to kind of stop that, you're going to get into trouble with precancer or cancers of the uterus. But we know that by supplementing progesterone, that completely negates that risk 100%. There's no concern whatsoever.
Okay. Another viewer says, I'm in my late 50s. I've never been on estrogen. Can I start now, even though I started to be in menopause?
Absolutely.
Within 10 years of menopause, we know is the greatest benefit, because hormones tend to be very preventative. They're not going to cure your heart disease, right? But they can affect your blood vessels and keep them dilated and keep you healthy. And so, but that doesn't mean that 10 years after, at age 60, all of a sudden they're terrible and they're dangerous. It just means that the risk-benefit profile will shift a little bit every year. So yes, if the 91-year-old with incontinence came in asking for hormones, that is probably not the right patient, right? But if you're 61 or 65 and you are healthy and you don't have a contraindication, that is a shared decision-making opportunity. It is never absolutely off the table. It is always a discussion.
All right. A 67-year-old patient with a history of osteoporosis wonders if estrogen would be beneficial to her.
Absolutely. We know that estrogen replacement therapy reduces risk of fracture and bone mineral density loss. So certainly if she has no other contraindication to use, I think it's a reasonable consideration.
Reasonable to have the discussion, certainly.
All right. Well, the pelvic floor plays a key role in the body for bladder control to core stability, but is often overlooked as a potential problem during perimenopause through menopause. Prairie Doc spoke with Monica Haar, a physical therapist at Avera Health in Brookings, who specializes in pelvic floor therapy.
Pelvic floor PT is just applying what we use in regular physical therapy to the pelvic floor. So for someone who has a dysfunction in their life, such as bladder leaking, bowel dysfunction like constipation or leaking, or pain with intercourse, as well as people who are both pregnant or postpartum, we're going to look at what they might have trouble with in their life that's not working in a functional way, and then we're going to work on muscle strengthening, muscle flexibility, muscle relaxation, and get the part of the body that is our pelvic floor working in the way we need to be successful in our life.
Hormones during perimenopause and menopause change, and it can directly affect the pelvic floor.
Within our pelvic floor, they're very responsible for maintaining muscle strength, muscle elasticity, muscle flexibility in the pelvic floor. And when we lose those functions as the hormones change through menopause, we see a lot of more dysfunction show up in the pelvic floor itself.
Haar says any exercise you do in your daily life can be a pelvic floor exercise.
Any exercise that you might do in your daily life to be strong can be a pelvic floor exercise if we just use the pelvic floor when we're doing it. So when we think of physical therapy being exercise, I might have somebody doing leg lifts or wall squats, but we're focusing on what's your pelvic floor doing. Are you using it in an adequate way when you're doing that exercise so that it's nice and strong? And then that applies to, hey, now it's going to work in my day-to-day life because I trained it to use it with other activities.
pelvic floor therapy is amazing, not just for perimenopause, menopause, after childbirth, I mean, for urinary incontinence. I mean, when do you send women to pelvic floor therapy?
Frequently, kind of for a whole host of concerns. Certainly any concerns over painful intercourse. Postpartum patients can benefit significantly. Carrying a pregnancy, delivery, whether there's trauma or no trauma associated with that, can certainly impact your pelvic floor. Urge incontinence, stress incontinence. If patients have symptomatic prolapse, they can benefit from it. So there are so many indications, and I think fortunately, just like perimenopause and menopause are having a moment, like pelvic floor PT is something that patients are really seeking out themselves now. They know that it's beneficial to them, and so it's very easy to accommodate a referral for them.
So a lot of people are finding stuff online, either through social media. They're seeing lots of influencers. How do you know what is true, what is good information, what's garbage, and they're just trying to sell you whatever they're selling? What are some red flags that women should look out when they're being, information is being thrown at them, but it may not necessarily be good information?
I think if it sounds too good to be true, unfortunately it probably is. And also if they're trying to sell you something, I always caution, like whenever I'm looking at something online, if someone's selling something, you kind of got to discern that, carefully. I'm not saying that they're trying to sell something bad, but it just may not be super beneficial for you.
I think if you go to someone and there's only one tool in the toolbox, like you have to buy this online, or we're going to roll on this cream and I'm going to put these things in that are going to last for 3 months, as opposed to giving you options and talking you through all the pros and cons, I'd be a little weary of that.
Okay. What about hormone testing? Everyone wants to come in and get their, check my FSH, check my LH, check everything. Is that helpful? You can buy home kits to check all of this. Do you recommend that for patients, and what do you do with that information when they bring it in?
Yeah, it's really hard because if you're perimenopausal, like your ovaries are truly in hormonal chaos. It's like reverse puberty, and so what you obtain in testing one day is a snapshot of that day and is not going to be representative of the whole picture or what you might get for a lab value 2 weeks later, 2 months later, whatever it is. So I tend to tell patients I certainly can order these tests, but I'm never going to make a clinical decision around these lab tests alone. Like, I'm going to look at you as a patient. I'm going to listen to what you are concerned about, what symptoms you're experiencing, and my treatment recommendation is going to be tailored to that, not to your labs. I think labs can be more helpful when you're really trying to decipher if someone has transitioned from perimenopause to officially menopause, because we can see some markers there that are pretty predictable of that. And so that might be helpful around decision making in that regard. But otherwise, I can order labs, and I'm happy to do that. I think it does feel like giving a patient something tangible, and people like that. They want information, they want data, they want numbers, but I try to just tee them up for the expectation that, like, this isn't going to sway what I recommend to you in any way.
So the home kits are probably not that
No home
helpful.
kits.
Very expensive.
Very expensive, and it's hard to even say like what the assays are that they're using and how predictable those results are. And like, again, that just seems like gouging patients for cash price things.
The one exception to labs that we all use is checking testosterone in women. And that's something where, if someone has a normal, although normal's very debatable in women, you may not opt to replace that. But if someone's particularly low, that's where it is helpful to know.
All right. Well, another viewer saying they are in perimenopause, but their libido is non-existent sometimes. What can be done?
It's common. So just like your estrogen and progesterone levels decline with perimenopause, so do your testosterone levels. And so one of the side effects of declining testosterone levels are an impact on your libido, as well as mood changes and energy levels declining as well. And so certainly transdermal testosterone therapy is a reasonable consideration for a patient to see if this improves that.
Women are always surprised to hear that we actually have almost 4 times as much testosterone in our bodies as we do estrogen. And so, it's just that they're measured in different units. And so if you look at them in lab values, they don't seem equivalent because they're not. But testosterone is huge for women. And I think it's really having a moment, and it's something that we all use as in our hormone toolkit.
All right. Another viewer says they've had weight gain since entering perimenopause. What can they do about it? It just won't come off. They've not changed their eating habits or exercise habits, but they just gain weight.
So that's, I feel like we hear this on repeat. Every woman who is going, in the mid 40s, early 40s, or 50s are having the same issues. Menopause itself doesn't cause weight gain, but there's a change in your normal adipose or fat distribution in your body centrally. And so women often will complain of central kind of collection of belly fat, which is, new to them and different. And also, a very common symptom of perimenopause and menopause is disrupted sleep, and so no one's sleeping, so you don't have energy to do your workouts. You try and do your workout, but it's just not as effective. So there's a lot of factors that play into things, but it's kind of a multifaceted thing that happens as far as the weight gain with menopause.
Muscle mass also decreases, and so the importance of weight-bearing exercises and weightlifting become even more important as you age. But like Annie was saying, your distribution of fat changes. So if you went to your local drugstore and got an in-body scan in your 30s and then in your 50s, you may have changed nothing and your weight may not change, but your visceral, the dangerous kind of fat will increase simply because you're in menopause.
All right. Well, there's another question kind of leads into, they're in perimenopause, have days during the month that they just wake up in the middle of the night and can't get back to sleep. Why and what can they do to help that?
Progesterone.
Yeah, that's definitely progesterone mediated. The fluctuations that occur during a cycle, you may notice those changes slightly when you're premenopausal, but then those changes, you really notice them a lot when your hormone levels are really chaotic, as Dr. Schiltz said.
So there's another viewer. They are 22 years old, but is there anything they can do in their 20s before perimenopause to help aid when that time comes? We're talking preventative, way down the road.
Yeah, I just get back to lifestyle choices. So weight-bearing exercise, strength training, adequate protein in your diet, prioritizing sleep, doing the things that we know are harmful. Don't smoke, don't vape. Protect yourself from sexually transmitted infections, doing anything to prevent comorbid conditions that are part of aging, so diabetes, heart disease, hypertension. Really prioritizing your health in your 20s is going to lead to you being a healthy 30-something, 40-something, 50-something. It sounds like they're already thinking about it, so they're probably doing everything right.
All right. Well, we've talked a lot about hormone replacement therapy. Viewers are asking what would be the contraindication? Why can't they take that? If they've had a history of a drug-induced blood clot, can they take estrogen? Can they do hormone replacement therapy?
So this is a controversial topic, and I think if you ask several different providers, you're going to get different answers. So if I have a patient who had a clot on birth control and now is interested in using estrogen to manage hot flashes and the transition through menopause. And the way we've approached it is I said, look, you are known to have a hormone-dependent clot, so I would not give you oral estrogen because we know that oral estrogen does increase your risk of clot, whereas transdermal does not. And so the approach we're taking right now is she's going to get a workup from her hepatologist. And if it comes back clear, we are going to start transdermal estrogen, which we know has very little, especially at low doses, has no increased risk of clot. So her baseline risk, yes, is elevated compared to the rest of the population, but that doesn't mean that adding that transdermal patch is going to increase her risk further. And that, that's definitely one end of the spectrum. There are lots of people who would say that's a hard no. But if you had a clot after surgery, that's a different type of clot. That's not a hormone-mediated clot. Really, the contraindications, and Kat mentioned these, are active liver disease, a recent heart attack, a recent stroke, a hormone-mediated clot recently, or an active hormone-dependent breast cancer. And very few people have those in this moment.
All right. Yes, another viewer is asking if you had breast cancer, can you do it? So it depends on what type of
that is
breast
cancer.
Cancer.
Yes, if it's not estrogen receptor positive, absolutely, but that's a very nuanced conversation, and that's not one, I'm still very much learning in this field. These guys have a lot more experience, and so I would defer to them on that, but that's a conversation to be had. It's definitely not a hard no. That is something you have to discuss with your provider.
Yeah, I think there's so much has been talked about with breast cancer and estrogen replacement therapy, and even vaginal estrogen has kind of earned a bad rap. And I think the reality is, even in patients with estrogen receptor sensitive breast cancer, vaginal estrogen for symptoms, as discussed earlier, is a very reasonable consideration. Systemic estrogen replacement is probably something where people would be a little bit wary of, but there really is not a reason that that patient has to suffer with, painful intercourse, frequent UTIs, atrophic changes, all those things.
Okay, so we've kind of hinted at it, but there's several different ways to do hormone replacement therapy. Could you explain which modalities or how you get the hormones into your system?
So there is a lot of different ways. In my practice, I tend to use transdermal estrogen the most commonly. Transdermal versus oral estrogen, both are very safe, but transdermal is considered to be the safest as far as risk profile. So I usually try and start that in a patch form, or there's also a gel that's very inexpensive. Cost does play a role, so I feel like the patch and the gels are the cheapest and covered best by insurance if they're going to be. So that's kind of where I tend to use estrogen. Progesterone, I really like oral micronized progesterone because it's the most bio-like. I tend to not try and use the term bioidentical because that's a pure marketing term. It is not, there's no basis of that term in actual evidence-based medicine and studies. So micronized progesterone is the most like what our body creates, and it also is not the progesterone that was used in the WHI trial. And all the studies to date that have been done with micronized progesterone do not show an increased risk of breast cancer. So I really like that. And then testosterone, in my practice, I only would use transdermal because that is what has been studied and seems also to be the safest.
Yeah, when I start hormones for a patient, I typically like to do kind of a staggered start because you're addressing so many issues and it's hard to tease out what fixed what, or if something didn't get relieved, what caused that. And so, I'll just start with an estrogen because that's essentially like where we start with everyone. Layer in a progesterone component if it's indicated. And there are a lot of women who've had a hysterectomy and they don't necessarily need a progesterone, but they will still benefit from that. And so if sleep disturbance is their biggest concern, when they said I had a hysterectomy 4 years, I'm like, you may still benefit from that. Let's try to address this with a progesterone component. And then layering in testosterone if that's indicated too. And teeing the patient up for the expectation that, there's gonna be tinkering. Like very rarely do I do this, this, and this, and they're like, slam dunk, see you back in a year. Like you usually have to set a cadence with them. Like I'm gonna see you back in 6 to 8 weeks. We're gonna see what did we improve upon, what did we miss, and how can we address it going forward.
Another viewer says their friend's doctor stopped prescribing her hormone replacement therapy after a hysterectomy. She started ordering it online. Is that safe?
I mean, unless it's cost plus drugs pharmacy and it was prescribed online, I would be leery of anything. If you don't need a prescription for it, it's probably not going to help you. But I think just as a general statement, you need a prescription for these things, and I don't think, unless you're going to Canada, maybe a little off book, but I don't think that.
Yeah, and having a hysterectomy is not a reason to come off of your hormones.
No.
So they're completely independent of each other. And in fact, if you had a hysterectomy and your ovaries removed at the same time, there may be more indication for you to stay on hormone therapy. So,
and that's something we were talking about on the ride up here, is how critical it is if you have your ovaries removed before the natural age of menopause, how life-saving it is to make sure those patients are started. And the number of people that we see in our offices who come in at 40 and say, oh yeah, I had a total hysterectomy does not mean removal of the ovaries, but they frequently mean it to mean the removal of the ovaries, but who were not placed on hormone replacement. Those women are twice as likely to die from cardiovascular disease. So it is critical that they are being offered hormone replacement as the standard of care.
And hysterectomy is kind of a blanket term
Yes.
thrown out about a lot of lay people.
Yeah.
And as a doctor, I'm like, what exactly was removed? Was it just the uterus? Was it the uterus and the ovaries, the uterus, ovaries, and tubes? Can you explain, when women have a hysterectomy, are there different levels of things that are removed and why? Are there times that you leave the ovaries, times you take the ovaries?
yeah, so it does get very nuanced, and it's hard for patients to understand exactly what we're recommending or what they had done, especially if you're looking back it was 20 years ago. Like, I can hardly remember what I did on Monday. So a hysterectomy is removing the uterus and almost always the cervix, which is the component of the uterus that lives inside the vagina, the lower uterine segment. We recommend removing fallopian tubes at the time of almost everyone's hysterectomy to reduce the risk of ovarian cancer, because the thought is that most ovarian cancers actually originate in the fallopian tube and spread to the ovary. Unless you are postmenopausal or have an ovarian reason to have your ovaries removed, we almost always leave your ovaries because we know that the risk of having your ovaries out premenopausally is detrimental to a patient in terms of life expectancy, mortality, cardiovascular disease, bone health, mental health, all the things like we've discussed. So there are a lot of layers to what surgery you could have done. Hopefully your surgeon is going to be very straightforward about specifically what they're removing. I mean, that's surgery 101. So yeah.
So then after women have had that procedure, how do they know when they go into menopause? If they still have their ovaries, but they've got no periods to guide them.
So menopause really is just one day in your entire life. It's kind of a transitional period that's very important. It doesn't necessarily, you don't need to know exactly what day or what year that happened, but I think most people have some sort of symptoms, although some people just stale and they'll have their hysterectomy, they don't have periods, and they don't have any issues at all. But I'd say most people have some symptoms that can kind of indicate that they're more either in perimenopause or menopause.
Okay. But even one without symptoms can benefit from hormone replacement, and one of the 3 or 4 FDA-approved indication for hormone replacement is osteopenia, which is the precursor to osteoporosis. And so any woman is eligible to use that for preventative measures because it does decrease your risk of fractures significantly.
Excellent. Another viewer asks, can a woman get pregnant during perimenopause?
Absolutely.
Yes. Yes.
Mm-hmm.
Yeah, I mean, even though the ovaries are kind of in that like chaotic pattern like we described, you are still ovulating often, and at any point you are certainly, it's possible for a pregnancy.
All right. Another viewer says, since entering perimenopause, I feel more anger leading up to my period. Is there something that happens during this phase that causes that?
Fluctuating hormones, specifically progesterone, is really the major mediator of that sort of PMS, premenstrual dysphoric disorder symptoms. So that is a very, very common symptom that we see in our offices routinely, as kind of a sense of irritability, rage. Decreased bandwidth, the inability to manage stressful situations when they have been able to before. Very, very common symptoms.
All right. Another viewer says, my heart sometimes flutters during menopausal hot flashes. Is that normal?
Well, it's part of, it's part of the menopausal, yes, it's common. But that is also something, I think, was it Oprah went to how many doctors with heart palpitations, how many cardiologists, and someone finally said, this is menopause. Because that's, there are estrogen receptors on every inch of your body, and so estrogen affects every single organ system, your brain, your bones, your heart, your blood vessels, and so the symptoms can be just outlandish sometimes. The things that you hear, you're like, how is that possible? But it is.
All right. And another viewer says, should I be worried about my mother's health? She's in her 70s, since she was pulled from hormone replacement therapy when she was in perimenopause.
So there's a whole generation of women that, because of the way the WHI, and the WHI wasn't a bad study. We got a lot of good information from that, and it showed that hormone replacement therapy was wonderful for a lot of reasons, but the way it was rolled out was really detrimental. And so there is a generation of women who unfortunately are going to be the most affected by that, and that's really the boomers, because it definitely isn't as beneficial to start it in your 70s, and we can't go back. However, progesterone and testosterone are still very safe at any age and with almost no contraindications, and so there are options. And even if you're having hot flashes in your 70s, you can use progesterone. Absolutely, that can help with hot flashes. We can use testosterone to help protect your bones, and it may even be protective against breast cancer. There's new studies coming out about that. So all is not lost, and there's still, hormones are only one tool in the toolkit, right? You still need to be exercising and lifting weights and eating right and doing all of those things, and so it helps, but all is not lost if you can't use hormones or you've reached an age where it's maybe no longer the safest option for you.
All right, wonderful. Well, Our winner is Anne. A book will be sent to you shortly. We'll be back after this.
Hello, my name is Dr. Ken Bartholomew, and I serve on the Healing Words Foundation Board, the nonprofit that runs Prairie Doc programming. Our mission is to enhance health and diminish suffering by communicating useful, science-based information respectfully and compassionately. Your donation supporting Prairie Doc programming makes an extraordinary difference. Gifts of any size enhance its impact in our state and beyond. Thank you for your generosity.
Don't miss out on the latest insights into health and wellness. Be sure to pick up a copy of your local newspaper or explore the Prairie Doc Perspective online, a weekly column dedicated to providing valuable information on health and medical topics. Access all previously published columns and stay informed by visiting www.prairiedoc.org.
As we finish up this evening's discussion, I would love to thank Dr. Schiltz, Dr. Siewert, and Dr. Thum for sharing their expertise with our viewers, and me. And thank you to all of our viewers for tuning in tonight. We appreciate your continued viewership and support as our mission as we continue to provide science-based health education. Don't forget to follow us on Facebook, Instagram, YouTube, and TikTok for more information and updates. If you missed sending in a question tonight or it didn't align with our topic, send your question to ask@prairiedoc.org to be answered on our weekly radio program, Prairie Doc Radio, Sundays at 6 a.m. and 1 p.m. on South Dakota Public Radio. And be sure to download and subscribe to the podcast version of this show and Prairie Doc Radio wherever podcasts can be found. Thank you for joining us on another On Call with the Prairie Doc. Until next time, as our founder, Dr. Holm, would say, stay healthy out there, people.
Join us this week as we host one of our viewers' favorite shows, Ask Anything. We focus on all medical topics affecting those in our viewing audience. Ask Anything next time on Call with the Prairie Doc. Major funding for On Call with the Prairie Doc has been provided by
At Avera, our nationally recognized health system will be right here with you, with care and coverage. Hello possibility. Hello healthy. Hello life. Avera, moving health forward.
Larson Manufacturing is proud to support On Call with the Prairie Doc as it continues to open doors for important medical information. And with the ongoing support of these individuals and institutions, Brookings Health System, South Dakota Academy of Family Physicians, Sanford Health, Avera Medical Group Brookings, Avera Heart Hospital, First Bank and Trust, Dakota Allergy and Asthma, Monument Health,